Dr. Erica Teleg is a stroke and cognitive neurologist. She finished her medical school and postgraduate residency in Manila, Philippines. She then proceeded to complete a 3-year stroke neurology fellowship with the Calgary Stroke Program, after which she proceeded to complete a behavioral and cognitive neurology fellowship under the direct supervision of Dr. Morris Friedman in Baycrest Health Sciences Center, University of Toronto. She is now currently practicing primarily as a stroke neurologist in the Kitchener-Waterloo Wellington region at Grand River Hospital, St. Mary's Hospital. She is 18 months into this role. And thank you very much, Dr. Teleg. I'll turn it over to you.
All right. Thank you, Tina, for that kind of introduction. So I'm actually excited and humbled to begin this series. And before I begin, I'm going to shout out to our group of hospitalists in Grand River Hospital. You do such amazing, excellent job. We are all stroke champions in this talk. And I do this for you, right? So before I begin, we will do a land acknowledgement. So Grand River Hospital and St. Mary's General Hospital acknowledges that the land on which we live and work today is located on the Haldimand Tract of 1784, a formally ratified agreement acknowledging 6 miles on either side of Grand River as a treaty territory belonging to 6 nations of the Grand River and is within the territory of the Haudenosaunee, Anishinaabe, and Shinoton people. In this territory, indigenous peoples continue to endure inequality, violence, and oppression due to colonialism. This is magnified by the historical and ongoing widespread failure by settlers and institutions to uphold their responsibilities within the dish with one spoon, wampum. Grand River and St. Mary's General Hospital acknowledges the enduring presence and deep traditional knowledge, laws, and philosophies of the indigenous peoples with whom we share this land today, their achievements and their contributions to our community. We are committed to understanding the impact of settler colonialism on the indigenous experience in order to envision and co-create a collaborative, respectful paths together in mutuality and reciprocity. I have no disclosures relating to the content of this talk. Let's climb a mountain. So I took this photo. So this is just one of the many peaks, which is an hour away from Calgary, right? And you visit Calgary, you visit Alberta, you visit Banff, and be amazed, right, by the magnificence of the peaks. But more importantly, that I'd like to emphasize, Canada, and particularly the Calgary Stroke Program, is a pioneer, together with other multi-centers in Canada and international as well, that has changed the landscape of how we deliver stroke to our patients now. We gotta be fast. I think that's the basic point in what I'd like to emphasize today. And these 2 trials is the ESCAPE trial. So this was 2015. I started my fellowship in Calgary in 2016, so the trial was complete. We were able to come up with and streamline the inclusion criteria and even extend the window time for patients to have that accessibility for EVT. And the recent one, which was led by Dr. Menon here, Bijan Menon, the tenecteplase, which has eased the giving of thrombolysis and also is more tissue specific for the clot and has less risk for hemorrhage. So these are the 2 pioneer trials that Calgary has led, and they're doing more, right? Every time, every year, right? So simplistic approach, how we were trained in Calgary: stroke, not stroke, weird stroke, right? So stroke, booyah, you know your patient, symptoms fit the localization, you do your workup, you're able to ascertain the risk factors and also the mechanism, you treat antithrombotic, anticoagulation, right? And then not stroke. 80% probability you are sure clinically this is unlikely a stroke story, and you do your workup and then you have other conditions, right? And if it's neurology, you do your neurologic or neuroimaging and see there may be other contributions or other things that may explain the neurological symptoms. And we have the weird stroke. And this is where the stroke in the young kind of falls into place, because we actually don't expect. And in textbooks, we were taught the usual case scenario for strokes are elderly patients with already a gamut of risk factors that we know of. Now, this is our objectives for today. So I'm going to just dive into it, right? So the epidemiology of strokes in the young, so 10 to 15% of strokes, usually the age is between 18 to 55 years old, so less than 60 years old. Pediatric strokes is another realm. Okay, so the Helsinki stroke in the young registry kind of like did a population study and had to kind of see which kind of age is more prevalent or more noticeable in both men and women, and male and female, right? So they've noticed men overpowered women in terms of strokes in the ages 45 to 49 years old, and the women younger, 15 to 30 years old, right? And there's the underlying mechanisms and risk factors are more diverse in the strokes in the young. And this is where we see it, right? In the emergency room, we don't really think of strokes in young patients, especially if these are in their 20s or in their 30s, right? And because we kind of assume there's no traditional risk factors, right? But in the end of the day, when we see the trend, young patients are now manifesting more of the traditional risk factors of stroke. So they overlap with that of our elderly patients, and we see it a lot. And this is where your threshold to admit the patient or do a workup is very low, so to be able to ascertain that you don't miss out on the traditional risk factors of stroke while not overthinking the unusual or atypical causes. The stroke mechanisms you are all nuanced about. The large vessel disease, your big pipes, cardioembolism, small vessel occlusion, and you have that that stroke of undetermined pathogenesis, right? So or other causes, right? And this is where you did your thorough workup, and you have two competing causes, and you have to decide which is causing the stroke or not, and the other is just noise versus sound. And then we do see cases that you did everything, you've exhausted all the workup, and still you cannot find an explanation for a stroke occurrence in the young. And then you have those that we need to work up because they don't have a complete evaluation, right? So cryptogenic is the term attributed to PFO, or patent foramen ovalis strokes, versus that of another term called ESIS, embolic stroke of undetermined source, wherein you check the plumbing and you go clot hunting in the body in a way, right? So in the young, they've noticed that the cardioembolism kind of mechanism is the one that is more prevalent, right? So it's 20 to 40%, right? Okay, we're climbing a mountain, right? So we're climbing a mountain. So this is my good friend, Dr. Andrew Lockie. He's now a stroke neurologist in Victoria. So I can't keep up with him. So I took this picture, right? So we were climbing the mountain. It's like, you have to keep up, he was saying, right? So while you climb mountains, right, you kind of doubt yourself, you doubt your existence for an hour or so, right? But then you try to decide whether you should just stop or continue to climb, right? So let's present the algorithm approach, right? We'll make it simple, right? Standard, we all do this: clinical history, physical exam, and then your investigations. And it's just being able to determine which investigations you have to do and has the highest yield to tell you the answer, right? This is my approach. And I think the stroke neurologists will tell you this. In the young, and even in our elderly patient, it's vessel, heart, blood. You have your other systems to consider. So this three compartment approach is important: vessel, heart, blood. Okay, so let's go in each compartment. So first is the clinical history. You will not find what you do not look for, right? So sometimes just by the history or just by the story of the patient, you nail it already. You kind of know neck pain, headache, I'm going to image, right? Even if I'm not sure it's a dissection or a cerebrovenous sinus thrombosis or the reversible vasoconstriction syndrome, right? Female specific risk factors are important, and you also have to understand, you need to know about heritage and genetic delineation if they are available, because we see many populations in Canada, right? And that would always include your family history, if there is at least first and second generation history of neurological conditions. And then if you do have suspicion of hypercoagulable states, right, whether it's miscarriages for our females, bleeding, sickle cell disease, malignancy, right? And also other etiologies, right? Especially if this patient has just had infection and so on and so forth, right? Now, very particular in your cardiovascular risk factors is your history for illicit drug use. So that includes this does not only include cannabis, cocaine, or methamphetamine. There are many things you need to ask and probe even more. And because of that, we're seeing a lot, right? I think we're not asking this as much as we should be in our young patients. So cannabis-related stroke is a reality, right? You know the cardiac complications of cannabis, whether it is used therapeutically or recreationally, but the neurovascular complications when you have other competing mechanisms, this is a risk factor, cannabis intake, because it can cause intracranial stenosis over time and could even be a primary cause for your RCVS and your ischemic stroke, therefore. Okay. Now, this is what I want to emphasize as well, is that there are risk factors unique to or more common among women. So we have to ask the use of birth control containing estrogen, because estrogen is a pro-inflammatory substance, right? So it can initiate the inflammatory cascade, especially if your patient has a predisposition to an autoimmune disease. Migraine with aura, we see it a lot, right? As a stroke mimic, it actually confers twofold increase in risk of ischemic stroke and smoking history, right? Now, a combination of this in an equation, birth control plus migraine with aura plus smoking history, increases the risk of stroke in women ninefold, but neither of the three, okay? And more importantly, pregnancy, especially for your young patients who are in the conception age, right? So history of miscarriages gives you a clue. You may be dealing with a hypercoagulable or a prothrombotic state or an autoimmune disease, which is your antiphospholipid syndrome. And that in itself as well is the prothrombotic state of pregnancy, right? So it's physiologic, right? Because the universe has given females a job to conceive, right? So strokes, hemorrhage, cerebral venous sinus thrombosis can all occur. There's also amniotic fluid embolism can also happen. And this is where antepartum, peripartum, and postpartum history is important, right? Because you want to understand if this patient has had eclampsia, right? Or is in eclampsia when you do get consults from the obstetrics team, right? And this is a multidisciplinary, right? So not too long ago, Dr. Gilk gave TPA to a pregnant patient and saved this patient, right? So pregnancy is not an absolute contraindication for thrombolysis, and I will confer you to the new update in the Canadian stroke best practices. So physical exam, you have your unusual causes. But actually, I've seen Susac syndrome, I've seen Ehlers-Danlos stroke in Calgary. So it may be not that uncommon if we are actually looking for it, right? And sometimes the first manifestation is an actual stroke. So Fabry's disease is an X-linked disorder, it's a lysosomal disorder. Skin, eyes. If you can do your fundoscopy, if there's an indication for you to do your fundoscopy, check the eyes. But the skin sometimes is something we kind of not look first, right? But if you see overt skin lesions, you have to think of the other syndromes as well. So Fabry's disease, you have that kind of petechiae that would blanch or change color, and there will be other systemic findings like a neuropathy, renal disease, or hypertension. You have your Marfan syndrome, right? So they have a certain kind of look, right? They have extreme limb length, they have joint laxity, and they will have other systemic findings as well. Ehlers-Danlos is also skin. They're very hypermobile, right? They're very flexible, and they also present with some sort of bleeding condition. And you have your cardiac findings, and you have your Susac syndrome and Eales disease, which is common among the Indian and Middle Eastern populations, right? So the Susac syndrome, brain, eye, ear. So they can present with neuropsychiatric symptoms, visual disturbance, and loss of hearing. And it's actually an arteriopathy, so small vessel disease. And you have your Eales disease, as I mentioned a while ago, and maybe at some point the ophthalmologist will be the first line, seeing these hemorrhages in the eye, and that is in itself true that the eyes are like the windows of the brain in a way, right? So that's important. So skin, right? So Fabry's disease, this is what it will look like, right? So it will blanch out, right? It will appear red, blue when you touch it or palpate. This is Nevin syndrome, livido reticularis, right? You have your hereditary hemorrhagic telangiectasia, which will appear like bruising some sort across the limbs and even the face. This is your Behcet syndrome. All of these confer a risk for strokes because it's connective tissue disease and autoimmune combined. You know this. This is the Maller rash of your SLE. And do you know this guy? This guy is in Ghost, right? So get off my train, right? So he's telling Patrick Swayze. So this is Vincent Shinelli. So he has Marfan's syndrome. And Ehlers-Danlos, you will see the skin is very extensible. And this is pseudosantoma elasticum. So it's also a connective tissue disorder, could bring about vasculitis. And this is what the vitreous hemorrhage will look like on eye exam. Okay? All right. So vessel, heart, blood. So that's how also you will be guided by your investigation. So neuroimaging, brain CT, carotid ultrasounds, they will not help. They're incomplete. You have to order your brain and neck CTA. You have to be able to ascertain the plumbing system, okay? And the brain MRI, which I will discuss why, what evidence and what information that can help you with. And then you have your cardiac investigation, so depends on what you are looking for, and the blood. Okay, so that's your hypercoagulable workup, tox screen, infectious, metabolic workup, and genetics. Now, so vessel, okay, we need to be able to see and visualize the vessels from their origins, right? So a CTA of the head and neck, right? So we're able to kind of chop the patient's right? So we kind of see why, if this is a dissection, we want to see if it dissects intracranially, right? Because that will confer a poorer outcome or like a more challenging to treat case, right? And there are other things you may also be able to look at the CTA to kind of determine if this is contributing to your stroke query or not, right? Carotid ultrasound is helpful, but it's not enough, okay? So I would don't hesitate. Do not be reluctant to order your neurovascular imaging. This is gold standard already. Okay, what do we see, right? So here in this first here, I wonder if you guys see my pointer. So this shelf-like protrusion here, this is a carotid web. So this will be read as incidental, right? But if you have patients who have recurrent TIAs and you've exhausted all the workup and you see this carotid shelf is actually confers atherosclerotic risk. We are not sure that there may be some artery plaque stuck here and it's distally embolizing intracranially. So that's something that you kind of put in the checklist of your stroke workup as well. Now you see here is your fibromuscular dysplasia, right? So you see beaded vessels, right? Most of the time it will be read incidental, right? But I see it in my TIA patients, right? I have to be able to ascertain or determine, is this fibromuscular dysplasia causing a problem? Number one. And number two, is this a picture of a connective tissue disorder, which we see as well, right? You see here a very fat basilar artery here, right? So this is called dolichoectasia. Again, it will be read incidental. So dolichoectasia is the vessels are ectatic, right? So they're weak. So these kinds of vessels, if you are presented with a stroke-like story, is a high risk for dissection, right? So patients need to know that they have this finding. So that's very important. And over time, as they age, they have to be able to be more vigilant to control risk factors for accelerated atherosclerosis. So that's your CTA, right? Now you have here your MRI. I order MRI, number one, to ascertain and differentiate between old changes of the brain versus new changes. That's one. Number two, it's a better camera. You are able to you hear me saying it a lot, right? My hospitalist group in GRH, you're able to kind of see the territory of the ischemia, right? And for your MRA, for your patients, or MR venogram for your patients who are conceiving, right? Because it's less you don't have radiation risk for your patients who are going to conceive, right? So that's important, right? So now also with the MRI is the pattern of white matter changes, right? Especially in a young patient, right? Because your differential diagnosis is a demyelinating disease, right? Or MS, right? So if it does not fit the stroke story, that's your differential diagnosis together with other neurological conditions that you do not want to miss, and call your neurologist to ascertain it better, right? So that's the kind of a CTA and your MRI, right? Microhemorrhages can only be appreciated in the MRI, not in the CT scan, unless you have a lobar hemorrhage in the CT scan, which is a bigger picture of a hemorrhage, right? But the microhemorrhages can only be ascertained in the MRI. In terms of the heart investigations, it depends on what you are looking for. We see a lot of PFOs, right? Now, very interestingly, we have patients who have negative TTE for PFO, and then for some reason, we decide to just do a TEE just to make sure, and they have a positive one. And also vice versa. They have in TTE, they have a positive PFO, but we do a TEE, there's none, right? So I will review the literature regarding these kind of findings, right? And it will be worthwhile for us to always discuss with our cardiologist, right? So the cardiologist will say to you to close or not to close, right? In terms of the PFO, right? So that's something we will discuss later. Depending also on the other suspicious, right, findings, because first of all, your first line is the TTE, right? And if you want to characterize whatever you see in TTE, you decide whether a TEE, a cardiac CT, or a cardiac MRI is better, right? And most of the time, we have the help of our cardiologist for that, right? So very important to be able to identify LV thrombus, because that is a game changer for the treatment that you are to give the patient, and also for the risk of recurrent strokes. Okay, so lots of things to consider in cardiac diseases predisposing to cerebral embolism in young adults. So this is just some of the disease entities that we will find. Most of you may have seen this, right, during your care for our complex patients in the stroke unit. Okay, so vessel, heart, blood. Okay, I get asked this a lot, right? There's a lot of variability in practice, right? The always most common questions that you ask me is why, when, and what. Now, so if we go by the stroke best practices, typically, routinely, we shouldn't be doing, unless you have certain amount of information or suspicion in selected situations, right? Female, pregnant, estrogen containing OCP, presence of PFO, and you already have no other reason for a stroke, for other mechanisms, right? So, and you are suspecting a hypercoagulable state, right? So this is the only time you do a hypercoagulable workup, right? Now, in terms of when, in some literature, the first week of a thrombotic event, lots of false positive in the testing. Some will say wait for at least 2 weeks and then repeat the testing in 6 months. Now, in some patients who are on antithrombotics and anticoagulation, that will also produce more noise than sound in your false positive findings, right? I asked my hematologist for help in some findings that are not clearly straightforward. And if there's any risk for me to consider recurrent strokes for my patient or change my approach to anticoagulation, right, or treatment, right, and also when you counsel the patient, right, because they're going to ask you, what is my risk of having a stroke again, right? So this is this is how I do it in my practice. So some of us, when we get the young patients, we do a hypercoagulable workup right away. It may help us or it may not, right? But routinely we should not be doing it unless you have that suspicion. Okay, so vessel, heart, blood, these are your inherited thrombophilia and acquired prothrombotic or hypercoagulable states. You don't want to miss an antiphospholipid syndrome, especially in your female patients, right? You don't want to miss that. And there are other types that you are already aware of as you order these in your hypercoagulable checklist, right? You have your factor V Leiden mutation, which is actually most common. It's very common. G20210A gene mutation. You have your protein C and S deficiency, antithrombin deficiency. So it will depend on you, and this is where the hematology team is helping you, right? Because they're more nuanced in terms of thrombosis, right? You have a thrombotic event, you suspect a hypercoagulable state is the cause or is contributing to the stroke event. You do your hypercoag workup and you ask help from the hematologist to kind of ascertain what is real and what is not, right? Now, if your patient is on a hypercoagulable state and you have evidence in your vessel that you are forming clots, in the heart you are forming clots, that's anticoagulation. That's no brainer for you guys, right? So that's important, right? Yeah, so this is just a guide for you in terms of what you are trying to understand when you order the hypercoagulable workup. Okay, so together with the blood work is genetics testing. And in the next slide, I will have a list for you when you think of genetics, right? Genetics testing, right? So it begins with family history and a good genogram of neurological symptoms and also other medical conditions as well, right? Now, you have to have a conversation. You have to take time in telling your patients or conversing with your patients why you want the genetics counseling, genetics testing done, right? So I refer the patients, or you have already probably know, we refer to the metabolics clinic in McMaster in Hamilton. They also have genetics counseling there, so which is important because some patients, they don't want to know, right? They don't want it um, they don't want the information to affect their way of living, but some would want to know because for the next generation, right? So this is important to consider. And when do you consider genetics testing, right? So you are already thinking maybe you need on a young age, on a young stroke, right? You have a family history, highly suggestive, but not necessarily present, monogenic forms, right? So and this will come up in the genogram, right? And then you don't have your conventional risk factors. And as I told you, the value of your MRI, right? So you, some of you may have encountered CADASIL, right? Which is a cerebral autosomal dominant subcortical infarcts with leukorrheusis, right? So white matter hyperintensity is unique to the brain. Especially you see it in a young patient, which is quite atypical, and your multiple microbleeds in the absence of known etiology, right? So if you have specific features that might suggest, I think I will do a genetics testing. Now, more often than not, you have also patients who come in with recurrent strokes, right? You've optimized their treatment, you've exhausted the workup. It's time to consider maybe you're dealing with something genetic, right? Or some predisposition to form strokes. Okay, look at the view, right? So I decided to go, right? Yeah, despite my short legs, right? So look at the view, right? Like you, in top of the mountains, right? It's breathtaking. It's very peaceful. It's quiet. You don't hear any unnecessary sound, but just nature, right? So if we could just not miss it, right? In terms of the diagnosis for strokes in the young, that's the best thing we can do for our young patient, right? So let's go to cases. I'm still okay with time, I think. Yep. Yep, I'm okay with that. Okay, I really wanted to present you with cases. So this one, case one. So it's a 30-year-old female, right-handed, headache and neck pain. My hospitalists already know, right? They already know, very classic, right? And mild balance problem. But you want to ask, right? So she's of Asian descent. She has risk factors for diet, for she has cardiovascular risk factors, which is diabetes, right? You want to probe on the neck pain, right? So what kind of movement, right? So and you have neurological symptoms. So this is important, right? Vertigo, ataxic, unsteady. She does not have chronic vertigo. She does not have chronic migraine. And then you ask, oh, I had a neck massage, right? So first of all, you will ask any chiropractic manipulation, right? So our chiropractors are actually better now. They know already what kind of movements can induce a query of a dissection, right? So and then I asked her, we asked her, can you search your phone? I want to see this neck massager, right? So it's a gun, right? It's like a neck massage gun. So it does not vibrate, but it produces force, kind of like a like a gun, right? Into the neck, right? So I'm not so sure what was the design, how it's gonna relieve neck pain for some sort, right? So weird stroke in itself because it's a young patient. So you want to understand what you want to do next and your threshold to image or not to image and go there for depending on what you have decided, right? So I've actually had patients who got discharged, right, from the ED, right, without having neuroimaging, and we see them in SPC, and we do our due diligence to do our vessel heart blood workup, and we see dissections, right? So we see it, not only your anterior circulation carotid dissection, we also see the vertebrobasilar dissection, which is a lot common in the younger population. Because you went to this talk, you will know, and you may have already know, we'll just do a CT, head and neck, and call who's on call, right? So if you all know, even if I'm not on call, I'm available for you to message, right? If you want me to check your scans, right? So dissections, right? So diagnostic evaluation, vessel, heart, blood, right? So vessel, you want to see everything. You want to see where your vessels originate and how they go extracranially and intracranially, right? Especially it's the neck, right? You want to be able to understand as well if the dissection, as I mentioned earlier, um, extends intracranially, because that is more challenging, and you may modify the treatment that you're going to give. You also want to see if there's any other things that may predispose this patient to have dissections, right? So you saw fibromuscular dysplasia, you saw carotid webs, you saw dolichoectasia as well, right? Because that in itself may warrant you to check the plumbing downstairs as well, right? So this is important. And then be guided with blood and heart and blood as you need, right? If some clues are coming out from your clinical history. Okay, so this is the patient scan, right? So you see very well. So front, back, right, left, right? You have your spine here, right? So this is C2, I think, right? So you see your left vertebral artery very nice and round and opacified, right? But there's none on the right. You don't see it, right? So you will also see it here, right? Here you see there is a non-opacification of this segment, right? So this is extracranial vertebral artery dissection. So on the review of the CTA intracranially, everything is open, right? And maybe this is why the patient has mild symptoms, right? But you don't know, right? From ground zero. So we MRI this patient, and you appreciate here a right cerebellar hemispheric stroke, right? Patient wants to go home. In general, young patients, they don't either go to hospitals. They don't want to go to hospital. They don't want to stay in the hospital, right? So she goes home after 3 days. We put her on dual antiplatelets. She comes back 2 days after, a little bit more unsteady, right? Still mild, but a lot unsteady, and she's worried. We scan her CT. We do a CTA again. It's the same dissection. There's no new dissection. We didn't see. It's the same. It's looking the same. We image her with. We did the brain MRI. We see a new stroke on the left, right? So two embolic strokes on bilateral cerebellar hemisphere. So you're kind of like hemming and hawing. That's a long way for a clot to travel, right? Although the basilar artery is your route, right? It's like your main pipe to cross, right? But it's such a long way for a clot to think, I'm gonna decide to clot on the left, right? So the question here is, are we still dealing with the primary dissection story, or should we be looking for something else, right? So neurovascular imaging for dissection, you will see the tear, right, in your eggshell. You will see the tapered flame shape here in letter B, right, in the CTA, and you will see a pseudoaneurysm as well because you tore the vessel, right? The vessel is torn, there creates a false lumen, and that in itself is your pseudoaneurysm, right? So you see that. And there are other factors associated with dissection per se, not only your carotid or your cervical carotid dissection, but also your posterior circulation dissections. And you will be guided if your patient presents with this type of phenotype of medical condition, right? So as I told you, 10 to 25% of strokes in the young are dissection, right? So don't miss it, right? We shouldn't be missing it, right? If you have that clear-cut story of a headache and neck pain. Trauma is usually the predisposing, most common mechanism, and you have your arteriopathies to consider as well, right? So for this patient, vessel, you saw the dissection, blood hypercoag is nil, cardiac nil, nothing. We didn't see anything. But you just decide to check, right? If we are dealing with something systemic embolism, right? Because you have different two vascular territories involved bilaterally in the cerebellar hemispheres, right? So we kind of like did a PET scan, right? My hospitalist was very good, right? He did a PET scan, right? He did discover some lymphadenopathy. The theory is clinically this patient is okay subjectively. There's nothing to consider or suspect for a malignancy or anything autoimmune, but what we decide is we will follow up what this lymphadenopathy means, right? So this patient has been subsequently followed up in internal medicine to check what this lymphadenopathy, if it increases in number or in size, then that's where we will go thereafter, right? So again, so this is your mechanism for your dissection. You see your tear, you create a false lumen, which can be a source of your soft plaques, right? Your soft emboli, which can distally travel upstairs, or the tear produces the occlusion, which I think is what we saw in this patient, and you develop your pseudoaneurysm, right? So what we do in terms of treatment, right? So before I go to treatment, these are just some of, and I've seen a couple, right? I've seen patients who have severe coughing or sneezing, they get dissection, roller coaster rides as well, right? And and several sports related injuries, right? When you move the neck out of the usual range of motion, right? So any kind of twisting. In terms of the chiropractic, it's the head nicking that you try to avoid and advise your patient not to undergo with their chiropractors. Okay. Treatment. So the treatment depends on what you see in the scan, the bleeding risk, and how your patient presents, right? So in the CADIS trial, there is no difference in terms of anticoagulation and antiplatelet therapy. Anticoagulation only increases your risk for hemorrhage, but we use it in patients who do have evidence of what we call an intraluminal thrombus. We call it the donut sign, right? Now, for our patient that we discussed, we were hemming and hawing because we put her on dual. Should we switch her, right, to a heparin, right, or to anticoagulation and C, right? So we had to observe her and not rush the admission, right? Because if she would have fluctuated or worsened, we would have switched her to anticoagulation if needed, right? So that's the general thinking, right? You be guided by the risk of bleeding in terms of the radiological features, right? And also what your MRI will show you, right? In terms of the size of the stroke, right? For her, we had to be careful because it's posterior fossa strokes, right? So less space for the hematoma to expand, right? The larger the ischemia, the higher the risk for it to bleed because it's large, right? So like a wound, the ischemia will bleed, right? It's a normal course of the stroke, of the ischemia, right? So we may expect bleeding, right? So this is where we had to be conservative and just do the dual antiplatelet and be guided by how she presents to us, right? So she's improved, right? She's not had any recurrent neurological conditions, right? Okay, all right, let's shift gears, okay? Case two, 36-year-old female, right-handed, hyperacute stroke, okay? Cold stroke. So she's a police officer, okay? Healthy, prime of her life. So this is a case I had in Calgary. So some cases you don't forget, right? So we scan, so it looks like a huge stroke, right? She's completely paralyzed on the left. She has inattention on the left. She's aphasic. She's a police officer, right? No known vascular risk factors except migraine, okay? But clinically, she's all her life she's been healthy, right? You scan her brain, no brainer. We give the juice, right? We treat this patient, right? Okay, so migraine with aura, as I mentioned earlier, with smoking and the use of OCP, right, increases your stroke by ninefold, right? So you must not dismiss your patients coming to you with migraines with aura and having the unusual aura symptoms, right? So I always ask my patients, what are your aura symptoms like? If they know it's their aura, they won't go to the ED, right? They won't call their family doctor. So there must be a reason why this aura is different, right? So when I say aura, it could be visual symptoms accompanying the migraine. It could be before the actual headache episode. It could be without the headache episode. So usually visual disturbances. Some patients have a lateralizing weakness or tingling. Some have cognition or speech arrest during the aura, but they know their aura, right? If the aura symptoms are not their usual aura symptoms when they get migraines, and it does not go away even with their usual prophylactic or migraine treatments, then something must be ongoing that I think we should investigate, right? So this is how I differentiate if my yield to do more for this patient is higher or lower, right? So this is important to ask, right? So for this patient, straight to EVT, right? So T thrombolysis straight to EVT. Neurointerventionalist, so how it's done for endovascular thrombectomy, the neurointerventionalist, it's like a video game for them, right? So they deploy the stent and try to open the vessel and retrieve the clot, right? The ideal pass is just a first pass, meaning one shot, we pull it, and the stent is deployed and the vessel is open. Now, what we noticed in this patient is that every time we deploy the stent, it keeps reoccluding, right? So deploy the stent, it reocclude. So after 3 passes, we usually stop already, okay? We stop, right? Because the risk of you dissecting the vessel is increasing, right? So each time the vessel gets recanalized, it reoccludes. So this is unfortunately her MRI. Okay, so she lost almost half of her right hemisphere. So she demised, right? So we didn't know. She underwent the compressive hemicraniectomy, and the family decided that they didn't want her to suffer anymore, right? So we go back, right? This is a young patient. There must be something we missed, right? So headache and neck pain, there's no dissection. It's a big, large vessel occlusion. It keeps reoccluding, right? So are we dealing with something that is intrinsic to a vessel pathology, right? So that's vessel. Blood. So we did the usual hypercoag workup, nothing. She has positive anti-NUMA antibody. So this is important because this is something, gives us a clue. Maybe this is something autoimmune because this is seen in SLE and Sjogren's disease. High ESR, CRP, mild thrombocytopenia, had some flu-like illness during her clinical stay. Everything else, no systemic embolism, right? That we could pick up from our workup, right? So what were we dealing with? So they gave consent for autopsy for this patient, and the pathologist has mentioned to us, right? So I've never seen such a healthy patient, right? But when I opened her lungs, okay, there were so many lymph nodes, right? So many lots, right? And they did pathology, and this is was the final diagnosis, right? So it was actually a sarcoidosis kind of picture, right? We go back to the CTA, right? So it was there. All the lymph nodes we see in the CTA, right? It was there. It was already made known to us from the beginning, right? So unusual for a healthy 36-year-old police officer to have unusual lymph nodes, right? And it was just unfortunate. The stroke was the early manifestation of the autoimmune problem, right? So I think in the other talk of the unusual causes of stroke, vasculitis will be thoroughly discussed, but it is important that in sarcoidosis, at least its relation to strokes, it's a large vessel vasculitis, which we saw in this patient. It's an M1. It's a big pipe, right? That was involved, right? So, and this is difficult to distinguish from your Takayasus, which is more apparent in your younger patients, and the giant cell arteritis is what we see in our elderly patients, right? So it's very important, right? If there's no other cause to go searching for these things, if clinically you have a high suspicion. Okay, I think I have two more cases. I think so. This one is also this is my last. This was a case that was it was my last day as a stroke fellow. So 34-year-old right-handed female. She's Filipino, so I was able to talk to her with my in my language, right? So it's easy, right? It was easy to pick up things. So it's non-specific symptoms, right? Nothing focal, nothing lateralizing. It's acute cognitive change. So she has lupus. She's stressed. She's not taking her meds, right? And 30 minutes, right? So we scan her, right? And then what stroke mechanisms are involved in SLE, right? So I'm not going to pull up a poll. You all know this. It's all of the above, right? You have a hypercoag state. You have a predisposition to vasculopathies. You have your antiphospholipid syndrome, and more importantly, your CVSC or thrombosis, right? So the answer is all of the above. Okay. These are your stroke mechanisms in patients who do have diagnosed SLE. So you're thinking vessel, heart, blood, right? So vessel, you will see vasculitis, you will see accelerated atherosclerosis. Blood, you will see um, hypercoagulable states, right? And also your infectious emboli could also be seen if these patients are immunosuppressed, right? And your cardiogenic emboli, limb sacs endocarditis is the one most commonly implicated. So you know this in the back of your mind, right? So when you have patients who have neurological symptoms and SLE, right? Okay, so we scan it, right? So we see this one, right? We see this one in the sagittal section, right? So my last day, so Dr. Hill here, so these are the three peaks, right? They led the escape trial. It was the staff, right? He comes in and says, what do you want to do? What do you want to do? So I said, I don't know what to do. So I don't know what to do. He's like, Erica, you're graduating already. You got to know what to do, right? You're staff. You're almost staff. So I told him, I'm not comfortable in giving the juice. So Dr. Hill always will tell you, give the juice. If there is no reason for you not to give the juice, right? Because you will regret not giving it in the end, right? Don't worry about hemorrhage. Don't worry about everything else. What will happen will happen. But if you have no contraindications to thrombolize, thrombolize. So we were arguing because he was saying this is just calcification. It may be just something that is there long before. You may be dealing with something that is new because it's 30 minutes. And then we do the CTA. I see something here, right? Like it's not clear, right, in terms of the continuity of the opacification of the vessels, right? So he tells me, I told him I'm not gonna give the juice, right? So I'm not comfortable. There must be some. I don't think this is an acute ischemic stroke that is happening that warrants her to have the juice, right? So he tells me, you defend this in the stroke rounds, right? You have to be able to defend why you decided, right? So I left the ER room for just 15 minutes. I get paged. She seized. So my patient seized, right? She had a seizure. Okay, this is her repeat scan in 15 minutes. So this is your venous hemorrhage, right? So this patient had cerebral venous sinus thrombosis, right? In your patients, in a patient with SLE, right? So I call him and he tells me, okay, you are ready. You are ready to be released to the world, right? So this is venous hemorrhage, right, from CVSD, and this is your hang-up of contrast, right? So if you check your CTA and you kind of suspect, call your RADs, right? You converse with your RADs. What do you see, right? What do you think? Don't you think that is something that is worthwhile investigating with the venogram? So we this patient was admitted. Yeah, she did well. She did well. She had a hemicraniectomy, so because of the increased intracranial pressure, but she did well, right? So be guided by when you need to do your hypercoagulable screening. So be guided by the criteria, so which is new from the 2023 EULAR, right? American College of Rheumatology. So testing includes the measurement of the following, right? So do your hypercoagulable workup. You may want to see if there are other thrombotic events in the system. So that's important. And for the treatment, it's your vitamin K antagonist. Even though you have venous hemorrhage, it's a balance, right? You give your vitamin K antagonist, right? And if you just need to just clear out the hemorrhage, call the neurosurgeon, right? Or there are some cases this because of the degree of hemorrhage, this patient can go into thrombectomy. They do thrombectomy, venous thrombectomy, and this is something we will discuss together with the neurointerventionalist, right? And thrombosis.ca has the comparison of your anticoagulants, right, later on, right? If this patient needs to be maintained or not. Okay, almost. Okay, case for two more cases. Healthy, plays tennis, wake up stroke, last seen normal. Okay, 15 minutes onset, 15 minutes comes to the ER, dense right hemiplegia, aphasia. The only history is hole in the heart, quote unquote, and OCPUs. Okay, weird stroke, right? This is the occlusion, right? Now, wake up strokes. If time of onset is not sure, right, or you use your last seen normal, wake up strokes are still eligible to receive the TNK or do EVT or EVT. And you base that decision on what the tissue tells you, right? So if there are early ischemic changes that are not established as a stroke already, that is established, give the juice, right? Give the juice, call the stroke code, okay? So I gave this patient TNK, okay? So this is the aspect scoring, right? So this is the scan of the patient, looks symmetrical, right? But the CT perfusion is going to tell you that if you don't do anything, this is what will be lost, right? More than 130 cc, right? So there was no hesitation. We gave TNK, we shipped the patient to Hamilton. Hamilton calls me, Erica, there's nothing to retrieve. The vessel is open, right? So this is the MRI of the patient, right? Versus that if you had not done something, right? So this is the patient MRS 0, patient is back to baseline. No other risk factors, vessel, blood. We close the PFO, no brainer, right? So PFO closure, use your rope scoring. So this is your risk for paradoxical embolism, right? So this is what your cardiologist will ask you. Should we close or not close, right? And your Pascal scoring, because the Pascal scoring is able to ascertain what the PFO looks like, and there are certain features that warrants the PFO to be a high risk for a stroke to happen. So PFO again is the shunt, right? That is present, right? So some patients will have small, moderate, large, and will not cause a problem throughout their lifetime unless it is challenged, right? So features that are high risk for strokes include there is a, you see here very tiny here, there's a septum, an aneurysmal intra-aortic septum, the Eustachian valve here, and then you have your Chiari network, right? So this is where you ask, we ask our cardiologists to help us, right? So this is it's in MedCalc. You can use this, right? So if you have ruled out other competing causes and the PFO is the only one that seems to be the elephant in the room, then it must be it, right? So the PFO is significant if the shunt, in terms of the bubble study, it's more than 20 microbubbles, right? So that you will know that the PFO is significant in size, right? So this is where you will ask, right? Now the Pascal scoring can also ascertain which patients are on possible, unlikely, or probable risk of having AFib post PFO closure, right? Because you close the PFO, but the patient gets an AFib, right? So after, right? So it will also guides the cardiologist as well. Okay, so go for fast. Things that may challenge the PFO is vigorous exercise, fever, flu-like illness. I had a patient who traveled, right? Who traveled, and the PFO got challenged, had a stroke. Valsalva maneuver. So any situation that can increase the right atrial pressure. Last case is a 44-year-old female with Down syndrome, right? So Down syndrome, gotta check, go back to up to date or your textbook. What are the stroke mechanisms in Down syndrome, right? What are they prone to? What are they predisposed to, right? So chronic cough and headache for the past week, sudden onset, right? Big right hemispheric stroke, left-sided weakness, aphasia, right? So vessel, blood, cardiac, right? Because there are also cardiac predisposition or diseases that the syndrome also confers, right? And their systems, right? So Dr. Gilk TNK this patient. So this is the vessel, right? You see that the left here is very continuous, right? Very early, right? Early ischemic change, not no ischemic changes, right? The CT scan. Some non-opacification. Not sure if this is non-occlusive thrombus or a stenotic vessel. You have, as you see here, you saw the CTA of the previous patient, right? Here, robust collaterals, right? So Moya syndrome is something that is usually seen in patients with Down syndrome, and the chronic cough and headache is a clue, is a clincher, right? So for this patient, Dr. Gilk gave the juice, TNK, patient is back to baseline, right? Now we have to understand, is the Moya going to be a problem in the future or not, right? So I think we planned to, Dr. Van Adel, our neurointerventionalist in Hamilton, is consulting on this case, and we kind of have to plan what is the risk that this Moya can give to this patient, right? Because this patient can also have a risk for hemorrhage, right? In terms of the Moya rupture of the vessels. Okay, so last slide, you're a little bit more refined now or streamlined, right? Stroke, yep, my young patients can also have traditional risk factors, right? So I'm gonna look for it as well. Not stroke, okay, no worries. I'm 80 to 100% sure it's not stroke, but I'm still gonna do my whole workup for other neurological conditions, and I'll do a CT, CTA, and or a brain MRI or an EEG, and consult my neurology colleagues, right? And then your weird stroke, right? So vessel, heart, blood, right? And then of course you can call me, right? At least when I'm available, right? In terms of your processing, how to proceed with this patient, right? So some interesting wildlife in Kitchener, Waterloo, right? So this is a heron. There's some interesting wildlife if you know where to look, right? So this I've noticed this bird is not so popular with the other birds. They don't like him so much, right? So, yeah, in summer in the park, right? So I saw this one. This one is my dog. He's now part of the wildlife in Kitchener Waterloo. He knows how to pose, and I don't know. The squirrels here have have quite a palate, right? For their onion ring here, as you see here. He's a consuming onion ring. And with that, I end my presentation. I think it's like a whirlwind of, um, of discussion, right? And I know you may have a lot of questions. So if we don't get the time today, you know how to get hold of me. This is my office is in the Kaufman building. I and you know how to message me, but message first, because I have a lot of fans, right? So you just message me first. And other references for your resource is always the Canadian Stroke Best Practice. It gets updated a lot, right? And the Canadian Stroke Consortium. So there are many versions of this talk, in the website, right? So I'd like to go back on those talks because they present the cases, different cases all the time, right? And of course, any other resources that you have been using for treating our stroke. So I'm going to stop sharing my screen here. And so are you able to share?
Yep, I believe I'm sharing. Maybe I can confirm. Are you able to see my screen?
Yes, we can see your screen, Tina.
Okay, thank you. So there was one question in the chat about wake up stroke. Sorry, let me just get to that. So wake up stroke, to give TNK, how to deal with transfer from other close by hospitals to Grand River, where they tell us out of the window.
Okay, nice question. Thanks, Chandy, for that question, because like I've also dealt with that, right? So Grand River Hospital, we're a district site, right? Stroke site. So we have the stroke physicians making that decision, right? So wake up stroke, right? So first of all, from where they come from, you already know they have scanned the patient, right? So CT scan and most always CTA, right? And they say it's a wake up stroke. The CTA and the CT scan and the stroke physician will review looks good, right? The decision to give TNK is no brainer, right? But the thing is, this is where there's lots of logistic rate limiting steps, right? In Guelph, I have some patients, they get the juice there, right? They consult the stroke team in Grand River Hospital, or they go straight to, or they consult critical and call Hamilton, right? Now, in other sites, I've had patients who are not comfortable in doing that and would like to ship to us, right? To Grand River Hospital, right? Now, I've raised this up in multiple occasions, right? Because we are district stroke center, we have mothership, right? So that's Hamilton, right? If on ground zero you see in the CT head you have early ischemic changes and you have a large vessel occlusion, that this warrants a good EVT candidate, at least from the advice of the bosses in our mothership, right? If the physician is comfortable with the stroke physician in the district stroke center to do a triple call with the Hamilton stroke team online, and the district stroke physician, and that's us, right, can actually help whoever is on the other end with the patient to make that decision, right? Because in the end of the day, the goal is to reduce the time. The goal is less than 30 minutes door to needle time, right? So it varies depending on the teams involved during a certain time of the day, right? Evenings or night times may be a challenge versus that of the daytimes, right, where there's more people. So I think Holly Arnold is in this meeting as well. We've conversed that, and Stefan as well. So we've conversed that, and we're going to try to kind of streamline, right? Because in the end of the day, where the patient can receive the treatment faster, that's what we should be doing, and kind of get rid of the rate limiting steps, right? That we could do. I hope I answered, Shanley. Happy to chat more.